Good morning. Thank you very much for the opportunity to be here today to talk about one of our projects. Well, I'm going to talk about a perhaps new concept, a new thing, how to use optics for diagnosis of tissue infection here, the UTI. Well, UTI is a very common condition. Almost everybody during the life experience it. And it affects people at any age range, especially infants, young children, elderly, and people with neurogenic conditions, in particular, people with a spinal cord injury. UTI in children, we are talking about the lower UTI. The incidence, this is the most perhaps common bacterial infection in children under 2 years old. 7.5% of girls, 2.4% of circumcised, and 10% of non-circumcised boys who present with fever are suffering from UTI. This rate will decrease gradually by puberty to 3% in girls and about 1% in boys. The importance of UTI is that the febrile UTI is the most common serious bacterial infection in childhood. And it can be a marker of urinary tract abnormalities as well as the spinal cord abnormalities. And it can easily, if untreated, turn to pyelonephritis and associated complications, renal scars, all those things, and even life-threatening conditions like the sepsis, especially in the newborn. Therefore, early detection and treatment of UTI as soon as possible perhaps is crucial in order to prevent of ascending the infection to upper urinary tract and reducing the risk of perhaps frequent UTI and bladder damage. Current diagnosis is based on the history, clinical symptoms. The hallmark is dysuria and vomiting perhaps in fever in children, and lab test urine analysis confirmed by urine culture using dipsticks, and there are some imaging and ultrasound works which are not really common in the practice. And the challenge is that getting reliable history and clinical symptoms from especially infants and young children is really difficult. Collecting a standard and clean catch urine sample, especially in children and people with spinal cord injury, again, might be challenging. And dipstick tests are not really always sensitive, comes with pulse results sometimes, and it's subjective method. So without going to the details of the pathophysiology, perhaps the most common thing is that the acute infection comes with bladder mucosa inflammation. And the bladder mucosa inflammation is associated with increasing bladder wall circulation, perfusion, and then oxygen consumption, supply and consumption. Therefore, it seems that a method capable of detecting local increase or changes in local oxygenation and perfusion, if access to the bladder wall, might be a solution. The trend of diagnostics in medicine, current trend to the futuristic perhaps trend, is changing from invasive procedures to semi-invasive, and from there to non-invasive, and even these days they are talking about non-contact procedures. It means without actually approaching the integrity of the tissue, getting biopsy or even body samples, be able to get information from the integrity of the tissues and the organ functions. And here, many of the modern optics and photonics methods are good fits. Infrared thermography spectroscopy is a method that look at the perhaps correlations between body temperature, tissue temperature, and inflammation. This is what they started to use at the airports when SARS started as a screening tool. And there are some studies using this infrared method to look at the skin infections skin wounds, diabetic wounds. As you can see here, a sample. But the limitation of this method is that the depth of penetration of infrared is up to perhaps 2 millimeters, so it can be just used for the skin perhaps. There are other methods like fluorescence spectroscopy that we can actually follow perfusion by looking at some dyes, but still we can't actually use it from transcutaneously from the surface of the skin. Raman Spectroscopy is another method, very good method, very fast approaching method, but still this works for superficial layer. And there are some use of laser Doppler duplex to look at the bladder wall perfusion, but still using duplex is not really simple. It's very complicated, complex, very expensive, and not really proper to look at the UTI, or at least be used for the UTI screening. Near-infrared spectroscopy is another optical method that actually uses light in the near to infrared spectrum of the light, somewhere here. And the specification of near infrared light is that it has the penetration into the tissue, unlike the infrared spectrum. So it means using near infrared, we can actually emit tissue. We can go inside the tissue up to, by current technology, up to 2 centimeters easily, and get some information from the tissue function, from especially tissue hemodynamics and oxygenation. In near infrared spectroscopy, we have at least one emitter which emit at least 2 wavelengths in the spectrum in near infrared, which is between 600 to 1000 nanometers. The light actually goes inside the tissue, and based on the specific wavelength, some amount of the photons would be absorbed by chromophores inside the tissue. The remainder would be detected by a detector, and the computer start to calculate this difference, emitted light and detected light, and translate this information to chromophore concentration in real time. As you can see here, it's a very standard figure of NIRS during the tissue hypoxia. The blue is the deoxygenated hemoglobin, red is oxygenated hemoglobin, and the green is total hemoglobin index of perfusion. So here I think that was a tourniquet application, and you can see after application of tourniquet here, tissue started to increase deoxygenated hemoglobin, oxygenated hemoglobin dropped. The new configurations and advanced technology of NIRS that uses multiple emitters and detectors will let us to use a specific mathematical analysis that can give us an absolute number. Beside the trend of changes in hemodynamics and oxygenation, we can have an absolute number, which is tissue oxygen saturation. Like arterial oxygen saturation that we use pulse oximeter to measure it, it is a tissue oxygen saturation, a combination of venous and arterial oxygenation inside the tissue. And it comes with a right-away number as a percentage. Normally the normal tissue, TSI, we call it tissue saturation index, is somewhere between 70 to 75% because of the composition of the venous and arteries. So this is a very, very good method to be used in clinics, because it can provide, beside the trend of changes, a number. Near-infrared spectroscopy has been used in medicine for, 10 to 15 years, mostly to monitor brain oxygenation, especially in children, immature children, or after heart surgery, when it's really important to have a measure, real-time, direct measure of brain oxygen saturation, as well as using to monitor grafts and tissue vitality, and to monitor muscle function. And we started here at UBC perhaps about 8-9 years ago to use this technology for the first time in urology. Advantages of this method is that it's totally non-invasive, absolutely non-invasive, real-time monitoring. It actually provides some direct information from physiology of the tissue by showing a real-time changes in hemodynamics and oxygenation. The validity of the method actually has been confirmed by many studies. It is not complex, it's really easy to use, to train to use, and simple to operate. It can be a handheld, portable, a very low weight, very even cheap device comparing the other diagnostic device. The limitations, however, is the most important thing. The depth of penetration is limited by 2.5 centimeters. So we can't actually go really deep into the body. If we want to do that, we have to perhaps use some implants or sensors inside the body. And also it's very sensitive to motion, so we have to use some filters and some mechanism to control the motions, which we do that without any problem.
Babak is also limited by the tissue, so if you're trying to go through bone, is that...
No, actually it penetrates bone. 2-3 weeks ago I was in a conference at San Francisco, and people from the orthopedic actually show how to use near-infrared spectroscopy for monitoring, for example, stress fractures. So easily it can penetrate into the tissue as well. To dental, even tissue, no problem with that. The amount of absorption, coefficient of absorption would be changed, but it can penetrate it. Just touching on some of our works that we have done using near-infrared spectroscopy to look at bladder function, because we look at bladder as a muscle, and we can very easily use near-infrared spectroscopy to look at muscle function. So we started to use wired and then later on wireless near-infrared spectroscopy to look at bladder hemodynamics and oxygenation during voiding and during filling. So as you can see here, we first started by defining the normal pattern of changes during voiding and filling. And this is one example of voiding, a normal voiding. As you can see, the bladder, a normal bladder can increase its oxygenated hemoglobin during the voiding to have a very strong muscle contraction. But in bladder dysfunctions, in different kinds of bladder dysfunctions, normally we don't see this increase during the voiding after permission to void. So what's happening is, instead of decrease, instead of increase, it starts to decrease, because the bladder, the dysfunctional or fatigued bladder cannot increase oxygenated hemoglobin or use it. Instead, for the contraction, it starts to consume the rest of the oxygen inside the bladder wall. So you are dealing with a muscle which is fatigued and cannot contract well. And then we showed that the same thing in the adults. Again, decreasing oxygenated hemoglobin during voiding. Recently, in a Grand Challenges Canada research, we actually went to Uganda and showed that the skin pigmentation is not a barrier, so no problem with pigmentation. Even we can easily monitor bladder. So we did a different study on adults and children in Uganda rural area. We developed actually this device for the first time for that project. And again, you can see a normal bladder, a pigmented skin, and a dysfunctional bladder. In a Ricanson-funded study at Dr. Michael's clinic, for the first time again, we look at the bladder function in people with spinal cord injury during simultaneous to urodynamics study. So here you can see a report of a urodynamics study in an overactive bladder in a person with spinal cord injury. This is the invasive perhaps procedure of the urodynamics. We just put our device over the bladder, fix it, and look at the real-time data during the filling. And this is our data coming from the surface of the skin, transcutaneous non-invasive data. You can compare and see how our data is following this invasive data, mirroring this. So whenever actually we had an increase in bladder, the trouser pressure, we had a drop in bladder wall oxygenation and tissue oxygen saturation. Again, for the first time, we invented a new method of signal analysis, and by that, regardless what's happening to the chromophores, by following the pattern of tissue pulsation, bladder pulsation, when it is under pressure, high pressure, and when it is not under pressure, we can define and actually differentiate the high pressure bladder from non or normal bladder. As you can see here, it's a magnified portion of the NIRS data, and you can see when there is no pressure, pressure actually is zero, we see a standard biphasic pattern of pulsation. This data is coming from the bladder wall using the NIRS. And here it is when the pressure actually increased, you can see the pattern is different. And again, when it gets back to the normal, again we can see the same thing. And with mathematical analysis software, we can look at the power and magnitude of these changes, and easily we can differentiate high pressure from low pressure. But today I want to focus on our new concept, how to use near-infrared spectroscopy, as I discussed, for diagnosis of UTI, or at least screening of the UTI in children. We started with children, and our target is to go after the people with spinal cord injury. I will tell you why. This actually just published 2 weeks ago in Journal of Pediatric Urology, a paper. The objective of the study was to determine if monitoring bladder oxygenation level as a measure of bladder mucosal inflammation using a modification of near-infrared spectroscopy can help us to detect the presence or absence of acute infection. We need some fresh acute UTI. Children who are affected by UTI comes to the doctors. We can recruit them before actually starting the antibiotic, and a control group to compare our data. For that, actually, because of the system here, perhaps, it's not really easy to get these fresh acute children with acute UTI. I went to Iran, in Tehran, in a pediatric urology center at the University of Tehran, because the health system is different. In Iran, like many countries, when there is a urology condition, they actually directly come to the urologist. If it's the child, they come directly to the pediatric urology. We don't have a family physician system like here, so it's really easy to recruit the fresh subjects in all areas. For that, actually, I traveled to Tehran, and with Dr. Babak, who is a very well-known internationally pediatric urology scientist, we started to collect data from a bunch of children with acute UTI before starting the antibiotic, and we got some age and gender matched children as a control group. Our exclusion criteria was any infection, fever, rather than the UTI, let's say. People with history of bladder dysfunction or recurrency or bladder surgery actually excluded. Gross hematuria, malignancy, and obesity was another exclusion criteria. The obesity, real overweight patients with more than 20 millimeter of adipose tissue over the bladder wall, over the pubis area, which is very rare, of course. The method was very simple. In a supine position, we first put our sensors over the bladder, fix it there for 1 minute and collect the data in real time, and then remove the sensor over the thigh muscle as the control zone and collected 1 minute data. We actually look at the TSI percentage of the bladder wall and the control side, vastus lateralis muscle. The system that we used was a specially resolved configuration, a kind of high-tech wireless compact device, as you can see here, with one channel. One channel means that at any time it can actually monitor just one point. Two channels means that at the same time we can look at 2 points of the body parts. The interrupted distance in this device was 4 centimeters, and it's really important because the depth of penetration is equal to the half of the interrupted distance, the distance between emitter and detector. So with this device, we had perhaps a depth of penetration of 2 centimeters. And the wavelength in this system was again in the near-infrared region. It transfers data through the Bluetooth to the computer in real time, and the sampling frequency was 10 Hz. The outcome measure was simply bladder tissue saturation index, BTSI, controls TSI, and the difference, we actually made this index, the difference between bladder and the control side. We calculated the average measure of BTSI, CTSI, and the difference over the 1 minute data collection and compared between the bladder and the control side. We also look at the possibility of correlations between these numbers with the age of the children. We had 24 patients. Well, actually, I collected data in 2 rounds in 2 years, consequent years. In the first year, we collected 12 patients, and the paper which is published actually includes those data. But here I'm reporting all the data together, which was 24 patients with acute UTI and comparing 24 control group. The sex was 4 male and 20 female as expected. The age, the mean was 52 months. The range was between 6 and 144 months. In all, in our cases, 83 of them actually expressed or showed dysuria, and in 67% we had fever. The urine analysis, 100% showed WBC and bacteriuria, and 83% the RBC, and the urine culture was positive in all of them. So really acute UTI. Here you can see the differences between the non-UTI, normal people, perhaps normal children, and the UTI group. The bladder TSI was in the normal group was 73%, comparing the 80% in UTI group. And the control side, we can see, was in the range of the normal, again between 70 to 75%. So the control group in both groups were in the normal range. And the differences, the TSI diff, the difference between bladder oxygen saturation, bladder wall, and tissue, the control tissue, as you can see here, was near to 0 perhaps in non-affected group, but 9%, 9.1 in UTI people. Again, you can see the control side, the amount was kind of equal to bladder TSI in non-affected, but in affected UTI people, actually that was significantly higher. BTSI were significantly higher in the UTI group. TSI diff were significantly higher than UTI group, and CTSI didn't show any significant difference between both groups. And as you can see here, how nicely actually differentiated between UTI group, the TSI diff measure, and non-UTI group here. So based on our data, we need to do further clinical studies with larger sample size, of course. But based on our data in 24 patients, our cutoff diagnostic point perhaps is a BTSI more than 75.8%. And when we see this, then we go after the TSI diff. And the TSI diff perhaps should be more than 5.2. During this period of data collection, we had some children with bladder extrophy, and because this is always a question, how you are sure that you are actually getting data from the bladder wall. We had this situation, so we used this opportunity to put our device exactly over the bladder wall, exposed bladder wall, and do the measurement again. And we had two trials to come for the follow-up, and we did both. And interestingly, before actually seeing this urine culture result that came 2 days after 2 days perhaps, the bladder TSI in one of them was high, 81%, and the TSI diff again was more than 5.2, 8.6. The other one, the bladder TSI was in the normal range, and the TSI diff again was in the normal range. Later on, when we got the urine culture, we realized that that one actually was positive with Klebsiella, and the other one was negative. So another perhaps confirmation of the method. In conclusion, we can say that perhaps bladder NIRS might be an option for screening the children with UTI. We are not saying that the definite diagnostic method at this time, but at least it can be used beside the others perhaps as a screening tool. This study actually presents the potential application of a handheld device that we started to actually make. Now we have the technology, and this is what we actually make. We have the technology, hardware and software of the near-infrared spectroscopy to have a two-channel device. It means that in future we can at the same time, in just 1 minute procedure, we can collect data from the bladder wall as well as the control side, instead of actually moving one sensor from one point to other point. And even in future, if we get to that point, maybe we can have a handheld device. Just you actually put it over the bladder, and in 30 seconds measurement, it can provide you with a light, green or red, saying that there's a problem, there's a red flag, or that's okay. So future direction perhaps is to running some multi-central studies with larger sample size to examine the sensitivity and specificity of the method, to study the possible correlations between bacteriuria and BTSI measure. We actually didn't have a chance to do that. And to study a possible correlation between the pathogen type and the measure that we see and we read. Might be something very interesting. And also, we started to think about how we can use the same technology to look at pyelonephritis. We did some subjects to show the feasibility. Actually, we could easily show the difference between both sides, comparing the other measurements. But this is a project perhaps for the future, in the future. And now, in a home monitoring projects led by Dr. Nigro and Dr. Setters, we are using the same technology to look at possible UTI in people with spinal cord injury. Right now at the Blossom Spinal Cord Center and London, Ontario, it's a multi-central study. We collected somewhere around 15 patients. So far, we showed that our data is confirming is correlated to urine test and confirming our previous observations in people with spinal cord injury. And the final goal is if we can show that it really works in these individuals, perhaps in future we can have a device for these guys, for this cohort, a handheld device every day, for example, at 10 a.m. They actually put it over the bladder, keep it there for 30 seconds. The data collected through the wireless system, smartphone, or internet goes to a diagnostic center, and in a diagnostic center there is a machine learning software that look at all these data, and when the data is out of the range, perhaps activate a red flag for care providers. This is perhaps a fantastic method for home monitoring and remote monitoring of bladder condition in these people who are all the time at the danger of UTI, and they can't actually feel dysuria. So when they come up with something related to UTI, it's already late normally. With that, maybe we can actually have a very early diagnostic method for the UTI in people with spinal cord injury. I would like to acknowledge my mentors and colleagues, Dr. Nagro, Dr. Andrew McNabb, Dr. Lynn Stadders, and Dr. Babak Shadgan. And I would like to thank the agencies, Rick Hansen Foundation, Urology Foundation of the Department, University of British Columbia, and IPO Center. Thank you very much.